Okay, our next clinic example, Jim, I don't see you. Where are you? There you are. Jim McKeon is the administrator of the doctor's clinic, and I got a chance to hear him share his experience a little earlier this morning. And some of you may feel like you've been in business for 100 years. The doctor's clinic actually has been in business for 100 years. And Jim will tell you a great story about how you deal with patient experience for some patients that have been with them for a really long time. So, Jim.
Thank you so much for the introduction. I am actually going to speak without any slides, so bear with me if I get a little disorganized at times. The doctor's clinic has been around for greater than 100 years in Salem, Oregon. We're the capital city, and we claim to be the premier primary care group in town. We're a little prejudiced, but we feel strongly about that. If I look at patient experience in the group, although the doctors don't probably appreciate what they did many years ago, they started down the road of good patient experience with a thought process that said, in essence, let's provide a clinic that provides one-stop shopping for patients. So let's bring all the services related to primary care into the clinic so that patients gravitate to the clinic for the care they need. So, for example, we have lab, we have x-ray, we do mammography, CT scanning, cardiac testing, ultrasound, injections, immunizations, you name it on a primary care level, for the most part, we do it. Then the clinic, in a lot of ways, went down the road on a very department-specific level and said, let's hold the supervisors responsible for the level of service within the department. So radiology, let's pick on radiology. The director and the manager of radiology said, we want to be the best place for a patient to get their x-ray. We don't want them going to the hospital. We don't want them going to a private clinic for their own mammographies. We want them to stay here. What can we do? And she went down a process and trained her techs, even though she didn't do it formally, of providing a service level that was really high for patients. And then we went to reception, and we had the same kind of conversations and referrals, and a lot of this conversation was what I would call operationally driven. It relates specifically to the process, the way things get done in the clinic. And then it evolved into conversations with staff about respect for patients, about paying attention to patients' needs. And one of the things that I have always go back to staff with is, we pay a lot of lip service to the statement, if patients weren't coming in our doors, we wouldn't have a business. We're in the business of taking care of patients. We've all said that to our staff. And in a lot of ways, these surveys give you the meat, the detail to help you define what those words mean and to lend some essence to them. I've had conversations with receptionists all my career, and the words that echo forward are, if you were the patient, how would you want to be treated? We go to great extremes to try and teach people, and all of that works to some level. So then we go down the road of a patient questionnaire and a satisfaction and an experience questionnaire. And in reality, what are we looking to do? We're looking to change the culture of the group. We're looking to say, let's have an overriding culture within the group that says, you, the patient, are important to us. We want to listen to what you want. We want to help you accomplish what's good for your health. So then you break it down by staff as one constituent group that pays attention to this. Patients being ultimately number one on the top of it. But the third piece of it is providers. And the conversation with providers about how they relate to patients in the exam room in so many ways impacts the way the patient feels about their total experience in the clinic. If they walk out of the exam room feeling, as our patient just pointed out, feeling that the provider listens and pays attention to the details of their illness or problem or situation, they feel better about their experience in the clinic. So it's a way of tying all of the pieces together into one progression. And our lead speaker said something about we live in interesting times and change. And I hearken back to a point in my career many years ago, probably around 1995 in San Diego. The medical director of an IPA at their annual meeting quoted the same quote. And we do live in an environment that's constantly changing. And that's probably what makes this transition so difficult, is we're looking at what is the benchmark, or what is the goal? What are we really trying to accomplish? And the numbers in these surveys help us define targets, help us to define topics of conversation. And the conversation will change depending on which group you're in, what type of patients you care for, what geographical location you're in. A discussion with a pediatric group about patient experience and talking to parents about their experience with children is dramatically different than talking to an 85-year-old lady whose husband has Alzheimer's. And the data is important, don't get me wrong. It gives us targets, it gives us things to look at and help focus efforts. But ultimately, you look at it, at least I do, from the realm of what we're trying to accomplish in the group. What's the composition of the group? And how do we use this data to constantly improve and get better outcomes from a patient perspective, better outcomes from a health perspective, better outcomes from a staff perspective? If staff feels that the group and the culture of the group is defined for taking care of patients, ultimately, all of our staff will say, I'm in the business of taking care of patients, and that's the job and career I want. Well, if the group lends the culture to that statement and reinforces it, then your staff is going to feel better working in your environment as well. So, you know, the doctor's clinic did patient surveys, 3, 4, 5 years ago, and we did a couple back-to-back, and we measured the results and we made some changes. And then we let it slide because we had other things that were going on in the group. Things like meaningful use, things like a transition to an electronic medical record. You all live through it just like I do. And it's a difficult discussion because in the realm of change, it's difficult to get everybody to focus. And yet what I'm really suggesting is that ultimately, if we don't get there, we're not succeeding in what we're trying to accomplish. And this is a great tool, from my perspective, to lend a focus to the discussion. There's no hard answers in this data. There's no, yes, I have to do this, no, I shouldn't do that. It's a kickoff point for a discussion. It's how do I sit in a room with a group of physicians and say, patients really want you to talk about barriers to care. You know, oh, I'm busy and I can't get to the health club and I don't pay attention to my diet. This is a difficult conversation for a lot of providers to have with patients, and yet patients want it. And to get physicians to understand that and providers to understand it sometimes is a difficult conversation. I just, really think it's a positive thing for all groups to do. I think we need to pay attention to our constituents, our patients, listen to what they want, try and set up a process and a system and a culture within the group that accomplishes those types of changes.
Thanks, Jim. You mind if I ask you a couple
Please do.
follow-up questions?
Yeah.
So in the earlier session, early this morning with the pilot clinics, you mentioned some of the challenges you're personally experiencing with your providers. Can you elaborate a little bit more on that?
We have both family practice and internal medicine. We have an age group of providers ranging from mid-30s to retirement age. And historically, providers, and if there are any providers in the audience, I don't mean this in disrespectful ways, but if you go back in history, providers were sat in an exam room, patients walked in, they were told what their lab values were, they were told what diet to follow, what tests to get, what lab tests to get, and they shook hands and walked out, and there was very little conversation. And ultimately, we're moving that fulcrum to a patient-oriented conversation. And it's a change for providers as well as patients and management. So that's a conversation that at times is difficult.
So what, have you found anything that works?
Well, we're just starting this process, to be honest with you. I think it's a one-on-one sometimes with docs. Sometimes it's groups and peer pressure. Some of the greatest ideas come from a couple of docs sitting around a table chatting. I do this, I do that, have you tried this? My definition, one of my definitions of a provider is the simple word teacher. They do great jobs teaching, and they do even more great jobs teaching each other.
Good. Questions for Jim? In the back, Colleen. Can you, Stephanie's coming with the microphone.
Thanks for sharing your experiences as a pioneer in this area. I really appreciate it. I'm curious about your comment about, you need to get engaged in it and we need to kind of work together, and I 100% agree. And so I'm curious whether you've engaged your patients on solutions from a quality improvement point of view, because I agree that I think it's a culture shift on both sides. It's a culture shift for providers, but it's also for patients, and I think they might have really great ideas about what you actually do with the results and great ideas about how you improve. So I'm just curious about that.
Well, over the years, we've done some stuff. We did patient satisfaction surveys, which is what they used to be called a couple of years ago, and there was a topic related to phones and how quickly phones were answered and things along those lines. And we actually did a targeted survey within the group to get some really detailed specifics from their perspective. Formally, at this point, we don't have a process to involve patients. I stand up here as a person who handles all the patient complaints. So part of my role is to try and focus that discussion on the issues that we're hearing about, understanding that that's a limited sample of disgruntled patients. Now, granted, I get about 4 or 5 calls a week because patients historically have no problem calling this clinic and saying, I was a patient 40 years ago and you're changed and I don't like it. But it's still a sample that's not really valid. And we have to talk about how we get patients involved in that change process.
Colleen, could you just, I thought you brought up an interesting point before we go to the next question. Can you talk a little bit about what you meant about how patients, that things are changing and it isn't just the clinic staff, that patients need to be engaged because their role might be different? Yeah, so can you say something about that?
Well, just within the patient-centered medical home, that's going to be different. The expectation is different, that this practice isn't, you're not just going there, but they want to be the hub. And there's a lot of expectations that need, shared expectations around that. And there's roles that the patient needs to play that need to be articulated well. And I mean, one of the things we're finding with our practice is that we're working with is we've hired a patient advisor on just to our project. And that perspective about how to go about those communications is really invaluable, particularly as you're talking about care coordination, because patients are doing the care coordination now. And so they really could give care coordinators really helpful, meaningful advice because they're already living the world.
Well, and we have hired a quality manager, and we're starting to have conversations like so many of you about care management, case management, team meetings, the role of the doctor and the patient in all of these conversations. To me, this is a dramatic change. This is, I don't know how else to say it. It's dramatic, and it's going to take some time and a lot of energy on all of our parts to succeed. I think patients need, I had a conversation with a patient. Let me give you an example of this. Patient called me up to complain about a provider, and his comment to me was, well, he didn't test my PSA quickly enough because I'm a patient who lived through the Vietnam era and I was exposed to Agent Orange. And every provider knows that those patients who are exposed to Agent Orange have a greater risk for cancer, prostate cancer. And I was like, well, I didn't live through the war, but I lived through that era and I didn't know that fact. And I said that to the patient, and I said to him, did you tell your provider that very statement? And the patient looked at me and said, no, why should I? because maybe the provider doesn't know it, and it would help the conversation if you shared some of your knowledge with the provider. Oh, and I think in healthcare in general, we do a really bad job in helping define expectations. What can the patient expect from the provider? And then the conversation that goes the other way that says, I, the patient, would really like you to do this for me. It's a two-way conversation, and historically, we don't do a great job with that conversation at all.
Great. Thanks. Another question?
Yeah, two quick questions. Number one, you mentioned multiple times the change of leads, the change of cultures. So given your 25 plus experiences, do you think medical home is the solution or is the lowest fat? Number two, you mentioned two aims of the triple aim. You mentioned about experience, mentioned about access. How about the cost side? From a veteran practitioner's point of view, how do you believe doctors, practitioners can help reduce the cost?
Okay, so is the medical home the solution? I've been in management of healthcare since I graduated college in '71. I have lived through probably 10 different varieties of change. Medical home is the current model that the industry feels is going to have an impact on the way we provide care. Nobody will say that we have enough doctors, that we have enough providers to provide the care that we need to for the growing size of population, especially with the new uninsured population going to be accessing care shortly. So we need to find a different model. I don't know that there's any bad part of medical home. I think there's lots of good things. I think helping get the patient involved in their expectations of care and what they want may alleviate some of the conflict between I, the provider, think you need this, and I, the patient, don't really care about that. It's a conversation. Why should we force a 92-year-old person, and I don't want to get into age and living expectations, to have a test or to have a procedure done when they don't feel strongly about it? You know, if you talk to a patient who's a 45-year-old newly diagnosed diabetic and say, well, you have to change your diet and you got to go to the health club 3 times a week and you got to take this medicine, and they're like, you know what, I really don't care about all that. I don't want to change my lifestyle. It's going to change the relationship. So I think it's a way to change. It's the current model that everybody is supporting. As with so much in healthcare, I think we give it a run for its money and see where it takes us.
Great.
The other point about providers and cost. As part of, and I'm going to step back to Friday when in my email showed up an email from CMS. I don't know how many of you got it. Hopefully a lot of you got it. Where it actually gave me the cost breakdown of hospitalizations, ER visits, and some figures by diagnosis for the cost of care in our patients over the last 2 months. So here it is, the beginning of March for all practical purposes, and I'm getting data from CMS on November and December experience. I don't know about the rest of you, but I'm like, wow, this is a change. And if we got transparent data that we can share with providers and help, I don't want to use the word educate, but help them understand the relationship between what they do in the exam room and the ultimate cost of care, and get them involved with the patient of expectations. Maybe the patient doesn't want to be hospitalized. Maybe they don't want that knee replacement surgery. It's a conversation that can have some impact. How much? I think the history books are going to write that book. I don't have an answer to that question. But I think there is an impact that can be had.
Thank you. Other questions or comments?
Many people grew up looking at the clinician as the all-knowing, my life and health are in their hands. They've got all the answers. And now we're talking about empowering patients to be part of that process. So I guess the question is, what experience do you have in helping patients know and understand their empowerment to be part of the process.
I don't know that I do, except, on a very personal level. There are those patients who do not want to be empowered. There are those patients who want to be told and guided, but then there are those patients who don't even ask the basic questions. And if you guide them down the road of understanding their illness and their problems, and the conversation ends up being questions rather than statements, when the conversation goes on between the provider and the patient, I believe both participants will learn. So that as opposed to, you have this diagnosis and you need to do these 3 things, it's, you have this diagnosis, here are 3 things that could possibly impact your health, your lifestyle, your risk for hospitalization, your risk for death. How do you, the patient, feel about being part of that? Do you want any part of it, or are you happy where you are? And let the patient guide their own care with the guidance of the scientific knowledge of the provider. It's a balance. I hope, does that?
Thank you. We have time for one last question. I think we had it here.
Actually, Sam kind of beat me to the question, but I want to delve into that a little bit further in terms of the kind of the culture shift of not only empowering the patient, but how have you worked with your providers to kind of give that up and give them that empowerment?
And so we're starting. We're going to start at a high level within the provider group of starting to have this conversation. What we're, in some ways, is asking them to give up control, to give up that source of power that says, I, the provider, will take care of you, the patient. For some providers, and I don't think it's an age-driven thing, I really don't. It's contrary to their nature because they want to do what they believe is good for the patient, despite what the patient may want, or in spite of, excuse me. I think it's just a conversation within the groups. I think provider to provider with some guidance, you can say to providers, well, patients are looking for you to talk to them about barriers to care, or patients are looking to talk to you about their emotional well-being. And how does that impact on their actual medical condition? A patient who's got high blood pressure, who's worried about their 25-year-old son, who's got 2 kids, who's just been fired, is a conversation about emotional health as well as the patient's high blood pressure. And a lot of the history of the relationship between patients and providers is driven by you have high blood pressure, take this pill. You need to relax, you need to go to the club and work out your frustrations, as opposed to helping the patient understand what's the real source of their blood pressure problem. I don't see a change overnight in any of this, but I think it's a worthwhile conversation that we all need to have.
Great, Jim. That's an excellent way to end. Thank you so much.